Hello and welcome to Derm School. Today we will be looking at the first part of fungal infections of the skin. This is the classification of fungal infections. It is divided into three, namely superficial fungal infection such as Candida, Malassezia, as well as dermatophytes. Second category is deeper chronic cutaneous fungal infections such as phaeohyphomycosis, example eumycetoma or chromoblastomycosis, as well as sporotrichosis. And lastly, the third category is systemic fungal infections with cutaneous dissemination, and this often affects the immunocompromised patients. Examples are cryptococcosis, histoplasmosis, blastomycosis, coccidioidomycosis, as well as thalaromycosis, which is what used to be known as penicillosis. So the common ones that we will be looking at in this lecture series are Candida, Malassezia, dermatophytes, as well as sporotrichosis. We shall now look at dermatophytosis. Dermatophytes are fungi which invade non-viable keratinized cutaneous structures, namely the stratum corneum, nails, and hairs. There are three main genera: Trichophyton, Microsporum, and Epidermophyton. Dermatophytosis refers to infection caused by dermatophytes. These are the routes of transmission from another person via fomites or direct contact, from animals such as dogs and cats, as well as from the soil. These are the risk factors for dermatophytosis. Host factors such as atopy, the use of topical and systemic glucocorticoids, ichthyosis, collagen vascular disease, and systemic immunosuppression. Next, you have local factors such as sweating, occlusion, occupational exposure, or tropical or semi-tropical climate which becomes humid. The names of dermatophytosis are based on the site. For example, beard, Tinea barbae; head, Tinea capitis; body, Tinea corporis; groin, Tinea cruris; face, Tinea faciei; hand, Tinea manum; foot, Tinea pedis; and nail, Tinea unguium. These are the different methods for the sampling for direct microscopy or culture. For the skin, you can collect the scale with the edge of the blade, the blunt edge, or using a glass slide or a brush. Then for direct microscopy, the scale is placed on the center of the slide, swept into a small pile and covered with a cover slip, and then potassium hydroxide is applied at the edge of the cover slip and gently heated. For nails, debris is collected with a blade or curette. For distal lateral subungual onychomycosis, you debride the undersurface of the nail or the nail bed or take clippings from the area. For superficial or proximal white onychomycosis, scrape the superficial nail plate. For proximal subungual onychomycosis, you may need to do a punch biopsy to bore through the nail plate and obtain the keratin from the undersurface. For hair, remove hairs with a needle holder or forceps and obtain the skin scales using brush, blade, or glass slide. Then place on the slide and cover with cover slip. Investigations, you can use Wood's lamp examination. This will have a blue-green fluorescence, for example, hair for microsporum. Next, direct microscopy from the sampling that we discussed earlier. So you will see the presence of septated tube-like structures. Fungal cultures, you need to use Sebarot's glucose medium. And for dermatopathology, you can do a skin biopsy. Topicals are imidazoles such as clotrimazole, miconazole, ketoconazole, conazole, and ceticonazole. Allyl amines such as naphthephin, terbinafine, and other agents including tolnaftate, cyclopyroxalamine, and what we commonly used here for onychomycosis, amorolfine nail lacquer. For systemic agents, these are essential for Tinea capitis and Tinea barbae. Examples are oral terbinafine, oral or intravenous itraconazole, as well as oral or intravenous fluconazole. How do you apply topical antifungals? This is what you must advise patients. So let's say that's the rash. You have to apply to the area of the rash as well as 2 centimeters surrounding the rash. This needs to be applied twice a day until the rash goes away and then continued another 1 to 2 more weeks over the whole area. There are 4 main types of tinea pedis. Firstly, the interdigital type, which can be dry scaling or maceration scaling and fissuring. You also have the moccasin type, the inflammatory or bullous type, as well as the ulcerative type. For tinea manum, it is often unilateral, affecting the dominant hand. Patients present with well-demarcated scaling patches with central clearing, hyperkeratosis, and fissures on the palm. They can extend onto the dorsum of the hand with follicular papules, nodules, and pustules. For the dyshydrotic type, there's the presence of papules, vesicles, and bullae on the palms and lateral fingers. Secondary changes may also occur, including lichen simplex chronicus, nodular prurigo, as well as secondary Staph aureus infection. It is usually associated with tinea pedis, cruris, or angium. This is a picture illustrating tinea manum. Next, tinea cruris, over the groins. You have large, scaling, well-demarcated, dull, red, tan, or brown plaques with central clearing. And the patients may have papules and pustules at the margins, as well as folliculitis. The common sites are on the groins and thighs, but may extend to the buttocks. For tinea corporis, this is tinea affecting the trunk, legs, arms, and neck. Patients have scaling, well-demarcated plaques with central clearing. These are usually annular or arcuate lesions. It can be single or multiple and can also be psoriasiform. For zoophilic types, they are more inflammatory with vesicles, pustules, and crusting at the margins. Patients with tinea corporis may also have papules, nodules, and pustules. For tinea facialis or tinea faciae, on the face, there's the presence of well-circumscribed macules or plaques of variable sizes, elevated border, and central clearing with minimal scaling. These are often pink to red, hyperpigmented in darker skin. Tinea capitis is often found in children with varied clinical presentations, including non-inflammatory scaling, scaling and broken off hairs, as well as severe painful inflammation with painful boggy nodules that drain pus. This is known as carrion and results in scarring alopecia. For ectotrix, this refers to infection that occurs outside the hair shaft. There is cuticle destruction and the organism is usually Microsporum species. For endotrix, this occurs within the hair shaft with no cuticle destruction, commonly due to trichophyton. Carrion, as we mentioned earlier, is a variant of endotrix with boggy inflammatory plaques. Favus is a variant of endotrix with arthrocornidia and aspaces within the hair shaft. For non-inflammatory variants of tinea capitis, grey patch. Patients have fine scaling and patches of alopecia. It is grey due to spores coating the hair. Black dot. Fine scaling with patches of alopecia, speckled with black dots, which are broken hair shafts due to endotrix infection. And for diffuse scaling, the alopecia can be subtle or absent. For inflammatory variants of tinea capitis, diffuse pustular type, you have patchy alopecia with pustules or folliculitis. Carrion, painful erythematous boggy plaque with alopecia and pustules. For favus, patients present with matted hair and yellow crusted cup-shaped lesions around the base of hairs. Tinea incognito occurs after topical glucocorticoids are applied to the skin, which is colonized or infected by dermatophytes. There are variably inflamed patches which are deep red or violaceous, and scaling is not apparent. For dermatophytic folliculitis, patients present with papules and pustules. They may also have epidermal atrophy. The second topic today is onychomycosis. Onychomycosis refers to fungal infection of the nail plate, and it is more common in the elderly. Toenails are more often affected than fingernails. In terms of etiology, it can be due to dermatophytes. Trichophyton rubrum is most common, as well as T. mentagrophytes. You can also have the presence of non-dermatophyte molds such as acremonium, fusarium, and aspergillus, as well as yeast such as Candida albicans and other species. Risk factors for onychomycosis: older age, more than 65 years, diabetics, immunocompromised, especially HIV, athletes, genetics, other comorbidities including tinea pedis, tinea manum, psoriasis, PVD, venous insufficiency, hallux valgus, smoking, asymmetric gait nail unit syndrome, Down syndrome, and obesity. While patient factors are chronic paronychia, hyperhidrosis, nail trauma, and communal bathing or changing facilities. This is the classification of onychomycosis. Firstly, distal and lateral subungual onychomycosis, DLSO. This is the most common type, and the infection begins at the disrupted hyponychium. There's discoloration, distal dystrophy, and hyperkeratosis. For superficial white onychomycosis, this occurs on the surface of the nail, of the dorsal nail, due to T. mentagrophytes or T. rubrum in children, and less commonly due to molds such as Acremonium, Fusarium, and Aspergillus terreus. The third type is known as proximal subungual onychomycosis, PSO. The fungal enters via the proximal nail fold and affects the ventral side of the proximal nail plate. Organism is usually T. rubrum, and the patients are often immunocompromised. In the endonyx type, it affects the interior of the nail plate and spares the nail bed. There's whitish discoloration. There's no hyperkeratosis or onycholysis. Common organisms are T. sudens and T. rubrum. These are pictures that illustrate the different types of onychomycosis. You have the distal lateral subungual onychomycosis, superficial white onychomycosis, proximal subungual onychomycosis, as well as total dystrophic onychomycosis. Other clinical features include subungual hyperkeratosis, referring to scaling under the nail, a jagged and crumbling free edge of the nail plate, thickened nail, yellowish, whitish, gray, or green discoloration, as well as associated tinea pedis. For Candida onychomycosis, it usually affects the fingernails, and patients present with onycholysis, as well as chronic paronychia. In immunocompromised patients, there's nail plate dystrophy and hyperkeratosis. These are the various treatment options for onychomycosis. Firstly, pharmacological, topical antifungals such as cyclopirox 8% lacquer, tavaborol 5% solution, efinaconazole 10% solution, or commonly used in our scenario, amorphine 5% lacquer. Medical nail avulsion for total nail involvement can be done using urea paste, and for oral antifungals, they may require extended course or pulse treatment. Examples with terbinafine, itraconazole, fluconazole, and posaconazole. Non-pharmacological treatments are usually adjuncts such as infrared laser therapy, photodynamic therapy, iontophoresis, or ultrasound. For secondary prevention, here are a few tips. Avoid occlusive footwear, avoid excessive sweating, use slippers in the gyms or pools, discard or treat footwear and socks, trim your nails short, avoid unhygienic cosmetic nail practices, and use prophylactic antifungals in the form of cream, lotion, or powder for the feet and toe webs, as well as treat diabetes. We will continue in the second part of the lecture in a different video. See you soon. And thank you for listening today.